layer, and then we know exactly the normal wall thickness. And in the small intestine, this wall thickness should be below 2 millimeters. Everything above 2 millimeters is suspicious. The same is true for the large intestine. And we also can usually measure the diameter if we don't have a lot of gas, and it should be 2.5 to 3 centimeters. Otherwise, we have a pre-stylotic dilatation for any reason, and in the large intestine, less than 5 centimeters. And this is all we have to do. So the criteria we want to assess are, first of all, wall thickness. That's the crucial thing to measure, and that's objective, and that helps a lot in evaluating patients with any intestinal inflammation. Of course, ultrasound is not specific. You cannot tell whether it's intestinal tuberculosis or Crohn's disease, or even in Switzerland around Christmas, we have a lot of Campylobacter jejuni infections. And this is because there's something called fondue chinoise, that's in fact a soup, and you put slices of meat into that soup and you eat it. And when you don't put it long enough into the soup, a part of the meat is still raw, and Campylobacter jejuni needs quite some time to be killed and heat inactivated. So around Christmas, when everybody has fondue chinoise, we have a lot of Campylobacter jejuni infections, and they look exactly like Crohn's disease. So it's a wall thickening of the terminal ileum up to 8 millimeters, and you would believe must be Crohn's disease, but antibiotics will solve the problem within 5 days. The other thing is the wall structure. You look at the stratification when it's lost. It's severe inflammation when it's made. In ulcerative colitis, it's always maintained, the stratification, but I come to that later. Then you look into the blood flow. There's something called the Lindbergh index. It's from 0 to 3, but it's a little bit sophisticated, and the inter-observer concordance is really bad, so you don't need it. You just need to say it's normal or there's increased blood flow indicating inflammation. Then you can look into complications like fistula formation, abscesses, strictures, enlarged lymph nodes, free fluid. So you can detect all those complications. You can also evaluate motility, something that is never possible when you have a normal cross-sectional imaging with CT scans or MRI. So you know whether you have a hyperperistalsis in front of a stricture or any problem there. And then there's something that's called fibrophatic complications. So around an inflamed area of the gut, there's always increased amount of connective tissue that is bright white and hyperechogenic. And this is always an indicator for inflammation. And you also find it in ulcerative colitis. So it's not true that ulcerative colitis, at least with imaging, is restricted to the mucosa. And of course, we find dilatation in patients with strictures. So we come to a first patient case, a male patient, 43 years, Crohn's disease. He was first diagnosed in 2005, had an ileocecal resection in 2015, and he was not very compliant to therapy, so he showed up sometimes, and then for years he didn't show up. And then he presented in March last year and had some abdominal pain over the last 2 months. He also had intermittent fever, but no diarrhea, and he said, I have a gastrointestinal infection in the family. My children brought it home from Kita, and I don't believe it's Crohn's disease, but I'm not sure. Let's have a look. And this is what we found in this patient, and you see a hyperechogenic wall thickening, and now the wall is much thicker than normal. There's no gas inside, and here you see areas where you see this dark line coming out of the wall and then ending up in an area that also contains some gas bubbles. So when you have such breaks of the mucosal layer of the bowel wall with gas bubbles somewhere outside the gut, that's most likely not a viral infection that the children brought home from kindergarten. Here you see it again. The lumen is really compressed. The bright layer in the middle is the lumen. The dark layer are the 3 layers of the bowel wall. that completely lost stratification, indicating the inflammation, and here you see the large abscess or several abscesses. Here's one, with gas bubbles inside. So this guy has an abscess, has several abscesses. Despite not having a lot of symptoms, we got the result right away. We called our surgeons to see the pictures, and he was referred to surgery, to resection. So of course I said this is not specific. We see the small thickening of terminal ileum in Crohn's disease and fungal infections, of course tuberculosis, lymphoma, neoplasia, and even in NSAID enteropathy in older patients. So of course we cannot discriminate, but cross-sectional imaging cannot discriminate for the reasons why there's a wall thickening either. So that's no disadvantage as compared to CT scans or MRI. And there's another important aspect that I also want to point out. You really can see the extent of, for example, ulcerative colitis or other forms of colitis, because what happens there is, don't believe anybody telling you that ulcerative colitis is restricted to the mucosa. When you look into ultrasound, it's definitely not. It may be that the pathologist only sees T lymphocytes in the mucosa. That might be true. But the most prominent layer that's altered in ulcerative colitis patients is the submucosa. So in the submucosa, obviously there's edema, and there are a lot of blood vessels, increased blood flow. So you find a really clear thickening of the submucosal layer in the area where ulcerative colitis patients have their inflammation. And so you can really discriminate inflamed areas from non-inflamed, the extent of the disease. And what you also see around here is some fibrofatty proliferation. So ulcerative colitis can also be monitored with ultrasound, easily with intestinal ultrasound. So typical situations in IBD, in an acute flare, you want to know whether there's improvement or non-improvement on therapy, so we monitor the treatment success, and we all know that our patients are sometimes unable to tell us really whether there's improvement or not. Yes, my bowel movements decreased from 6 to 4, I'm still feeling cramping, but when you see the bowel wall has normalized, you know that those symptoms will go away soon. So we can also encourage them to stay on therapy when they say, I don't feel a big improvement. When there's chronic activity, we can intensify, for example, the 5-ASA treatment, we can switch to a different mode of action. But we can reevaluate when there's absolutely no success with our therapy. We go back and think about other reasons for this bowel wall thickening, such as tuberculosis. And of course, you see more patients, but I have to say we had 5 patients with intestinal tuberculosis over the last 2 years, so it's also increasing numbers in Switzerland. Traveling, people coming from other countries to Switzerland, so we see it more often. In remission, as I said, patients come and tell you, there has been an infection in my family, I now have diarrhea, is it a flare, is it no flare? You need to make a decision rapidly, and you don't want to wait, and you can do that within 5 minutes. Also residual symptoms, when the bowel wall thickening has completely disappeared, you can tell the patient, listen, I think we have a successful treatment. When we still have symptoms, it's mainly functional. So patients also are more adherent to therapy when they see, you can talk to them while you show it that they have improvement. And sometimes what we also do when we have patients on azathioprine, we don't want to treat them forever. So what do you do when you want to stop azathioprine? Stop and wait until they have symptoms to know whether you can restart it. No, what we do is we reduce the dosage by 50% and then to 25%, and we do ultrasound monitoring every 6 to 8 weeks. And when we see that the bowel wall becomes thicker under the reduction therapy, we restart the azathioprine before they have a flare or really have symptoms. That's really helpful because you don't want to go with your patients into a new flare of the disease. You want to avoid that. And it's much easier to recommend also stopping of therapies because you can tell the patients, we will notice when you have alterations, when you have local inflammations before you get the symptoms. So they feel much safer when they stop therapy. We do a lot more stopping. Now here you see something that's a stenosis and a pre-stenotic dilatation, and now the movie doesn't run, perhaps you could start it, because you nicely will see here you have the pre-stenotic dilatation, and you see with how much pressure the fluid content, the stool is going through this stricture, right? It's a stricture after surgery, so short stricture. You also see the length of the stricture, and you can decide whether you want to do a balloon dilatation or refer the patient to another surgery. In this case, very short stricture, definitely would do a balloon dilatation. So this also gives you additional information to how to proceed for this patient. And now we have another patient where we saw, you cannot see it very well, but there was again gas bubbles in a structure outside the gut. So that was a Crohn's disease patient with a fistula. And here you see a typical case of active ulcerative colitis, and you can clearly see the stratification is maintained, so you have all three layers, but around the colon, the large bowel, you have this bright increased tissue area. This is the fibrophatic proliferation. You have all the three layers, but the submucosa is increased in thickness, most prominent. So this is how we would then measure the activity of ulcerative colitis and are able to tell the patient what extent his colitis will have. And here another example, patient with active Crohn's disease. Again, we see around the terminal ileum this fibrophatic proliferation. And the lost stratification. So in Crohn's disease, when you have active inflammation, usually you lose the stratification. And also with colitis, it's maintained with a huge submucosal thickening. Here you see again, the lumen is compressed. It's this whitish area in the middle, and the increased bowel wall thickness up to 8 millimeters. So I would say intestinal ultrasound is a useful tool for diagnosis and monitoring of IBD as well as other intestinal inflammatory diseases, finding abscesses quickly, finding complications quickly, doing it right when you see the patient with really low costs. You can make an initial diagnosis, monitor therapeutic success, see whether there's recurrence of the disease, see abscess formations, ascites, fistulas, extraintestinal abdominal complications, and of course diagnosis of various other intestinal diseases. So I would not want to work without that anymore. It's in my outpatient office available, and I have to say that also patients get a little bit addicted to that. So they come and say, I'm doing fine, but could you do an ultrasound just to make sure I have no activity? So we do a lot of ultrasounds. They are not in Switzerland, they are not reimbursed very well. So I earn, for my department, earns like around $80 for an ultrasound, and I would earn like $800 with a colonoscopy, so 10 times more. But I think we do medicine for the patients and not for the budget of the department. So this is why I absolutely prefer intestinal ultrasound. And as I said, just do it, because it's easy to learn. Those handheld devices you don't need to push around the big machines. The big machines are better to some extent when you have difficult questions, but those handheld devices, you can take them anywhere you want to. You can use your cell phone to connect to those transducers, and you get the information you want right wherever you are with your patient. Thank you for your attention.
Did anybody want to ask her any questions? Sure. Yeah, go for it.
Daniel.
Can I ask you, how much validation have you done, or say, comparison of sonar count against Rutgers as a means of evaluating Crohn's disease with the introduction of treatment?
Well, as I showed you this meta-analysis, there are so many validation studies out there now that I think it's really a validated method. I mean, sensitivity and specificity is really high. And it really depends a little bit who does the validation studies. So usually when gastroenterologists in Europe do the validation studies, the results are a little bit better as compared to radiologists. But I think the results on specificity and sensitivity are always very good, especially in the large bowel and the ileum. Ultrasound is less sensitive in the jejunum, of course. But I think also MRI and CT have their problems when it's done jejunum.
And could I ask you, obviously not with the patient at the bedside, but intraoperatively, has anybody looked at ultrasound of lymph nodes to predict intraoperatively whether they've got all the lymph nodes that you could take out? So, we must get 12 lymph nodes in a malignant resection, and can the sonar help you with that?
There are also studies, right, finding enlarged lymph nodes, especially in colorectal cancer patients. Yeah. So this is done intraoperatively. The results are not as good for detecting, because it's also the structure of the lymph node, and there's a lot of subjective feeling about whether the structure is altered or not. There are small lymph nodes that contain malignant cells. So I would not trust completely ultrasound with respect to the detection of changed lymph nodes. This is, to my opinion, difficult, but every imaging has problems with that, right? Because it's no histology. But what comes is that there are ultrasound, so sort of antibodies against tumor antigens that have like gas bubbles, and they bind to those antigens, and so they are like contrast agents that you can use in ultrasound, not more specific as compared to the ones that we had in the past. But this is a little bit sophisticated, and development is going on, and we have to see what happens.
Yeah, thanks for that fantastic presentation. I'm a background in having to do echocardiography. I've done it for many years. So I have two questions. First is, have you used M-mode, to help you measurements of bowel thickness, with various, whether it's UC or Crohn's, whether it helps with the flares, plus M-mode. And then my second question is around, in our setting, we have lots of tuberculosis, especially in the setting of HIV, which often have disseminated TB. And so have you found that this in ultrasound to be a benefit to somehow differentiating between TB and Crohn's? You did mention it in your talk, but I'm not sure if the literature plays out to that. Thank you.
No, I don't think you can discriminate between TB and Crohn's in ultrasound. I was thinking about a patient that we have recently that had the diagnosis of Crohn's disease, went on a trip home, was HIV positive, came back, and we all thought he had a flare of Crohn's disease, and it turned out to be an abscess of tuberculosis that he acquired, most likely on this journey. So no, it's not possible, especially when you have the co-diagnosis of Crohn's and then tuberculosis in those patients. It's not specific, but on the other hand, MRI or CT scan also won't tell you exactly whether it's tuberculosis or Crohn's disease. You have enlarged lymph nodes in both diseases. You have really enlarged lymph nodes in many Crohn's patients, so this is also no way to discriminate. So the imaging cannot tell you. As I said, there are new contrast agents that are developed. There's also at the ETH series, they are working on that, and they are more specific, and they want to combine that with antibodies. antibodies that recognize certain structures, and perhaps then we have a chance to do a discrimination between the diseases. And well, ECHO with the imaging guidelines has accepted ultrasound as a useful tool, and they also provide now those courses in intestinal ultrasound. You know that IBUS, Thorsten Koharczyk and Christian Maase have set up a huge program, also training people. So I think it's well accepted with ECHO as a diagnostic tool, and also reflected in guidelines that you can use it. When you ask me about our surgeons, whether they accept the ultrasound imaging, then I would say it really depends on whether I can get them to the patient when I do the ultrasound. When I do the ultrasound and show the surgeons right at the moment, here's the abscess, here's the stricture, we need to do something, they don't want to get additional CT scans or MRIs. When I just show them the ultrasound pictures, they usually don't trust me and want another MRI or CT scan before surgery. So the live picture is much more convincing than what you can put on any prints or safe pictures in ultrasound. So our surgeons tell me, if I'm available, I will come and have a look at your exam, and that happens, I would say, in 30% of the cases, and the other 60 to 70% of the cases we still will have cross-sectional imaging with CT or MRI before surgery.
Thanks so much, Carol. Okay, everybody's